All right, we'll get started. My name is Darin Doumite. You can see on the slide there. I grew up in Southwest Louisiana in Kinder. Have a lot of family in the area. Grew up with 5 siblings, so always wanted to come back to the Lake Charles or Southwest Louisiana. Ended up in Jennings for 5 years, practicing general surgery. My wife is also a general surgeon. She does a lot of colon work with me as well. She focuses a lot more on breast cancer, but she gave a talk a few months ago, or last month actually. Y'all may have met her then. The focus of this talk initially was mostly going to be on the actual surgical aspect of colon cancer, kind of what we do if you're diagnosed, but I felt maybe it'd be fitting, since this is Colon Awareness Month, we should also include a little bit about screening for colon cancer and what you should do in order to prevent is there something we can do to prevent colon cancer, and how we go about that. So, as I said, it is Colorectal Awareness Month. The brief summary of what this talk is going to cover is kind of what is colon cancer, your risk factors, what we can do to prevent or early detection, and then the surgical management and some newer technology out there for management of colon cancer once you're diagnosed. So all cancers are essentially the same. They're malignant growth or uncontrolled growth of cells. Specifically, it's a little bit confusing. People say, well, I have an uncle had rectal cancer, I have colon cancer. Is it the same? Essentially, it is the same. It's the same tract, the GI tract. It's just anatomically in a different place. And the treatment is somewhat different. So you'll see oftentimes in the paper, or when you read online, colorectal cancer, and why didn't I get radiation? I had colon cancer, and they did get radiation. Well, it's different. The treatment after surgery before is different for colon and rectum, but oftentimes they group them together, the name. But just to be clear, they are actually treated a little bit different as far as chemo or radiation, so those should be differentiated. For the most part, when you're talking about colon cancer, you find in the colon or rectum are carcinoids and other types of lymph node cancers, lymphomas, GIST cell. But for the most part, when you're talking about colon cancer, you're talking about adenocarcinoma. Colon cancer is a lot more common than most people think. If we had 60 or 70 people in here, you're talking probably 4 of you are going to be diagnosed with colon cancer. I'm sure most people know someone personally in the family or a friend that's been diagnosed with colon cancer. It's a lot more common than I think the general public believes, and it's the second leading cause of cancer death in America. There's going to be almost 150,000 new cases of colon cancer this year alone, and over 51,000 deaths from colon cancer alone in 2019. Survival is strictly dependent upon stage at diagnosis. And that's why we stress in Colon Awareness Month the importance of getting screened earlier and earlier. And we've moved the guidelines down to start getting your colonoscopies a little bit earlier than 50. And when I talk about the survival, you can see this is not, you don't have to read any of this other than you can see stage for stage, if you're being stage 1 goes across the board for all cancer. Stage 1 is early cancer. Stage 4 is late cancer, it's spread. So if you look at the survival rate for colon cancer, this is actually extremely good. We've come a long way in the past 20, 30 years. These numbers were about 20% less in the 1970s and 80s. Stage 1, 94% 5-year survival. I mean, that's excellent for cancer stage survival. And then, as you can see, as you progress along and get later stage, the survival is at 5 years is very low. So, everyone wants to know, I have this cancer. How did it start? Where did it come from? They start off as these little precancerous lesions called polyps. Now, very important to remember about polyps. If you have polyps, of course, you should get screened a lot. Your interval between screening is going to be a lot less. But however, there are different types of polyps. There are hyperplastic polyps. These have zero risk of cancer in them. Those are just essentially little benign bumps in your colon. They have no risk of cancer. So if your endoscopist or GI doctor comes out and tells you that you had 5 polyps and he burned them all, we need to know, well, are there any risk of cancer in these polyps? Because if these were precancerous polyps, then you probably need a scope within about 3 years and not the full 10. And then there are the other types of polyps called adenomas, and these do carry a risk of cancer. It depends on the type of adenoma, but that's, way beyond this talk. But just know cancers come from adenomas. So they start off as these small, and you can see by the picture, this is very smooth. This is a typical polyp. It does not, I'll show you a picture of cancer later. This does not look, it's just a little benign, smooth. Cancer usually very rough or just very regular looking. This is benign. This is the treatment. You have a colonoscopy. The GI doctor goes in, snares it with a little loop, pulls it out. You're done. This left untreated will become cancer. So the importance again of getting a colonoscopy, go get your colonoscopy, prevent the occurrence of cancer. Moving on, I think I was going to skip this and go forward one, talking about how does colon cancer spread. It's important to know, not to write down and memorize the staging, but in general, when you're talking about colon cancer staging, everyone wants to know what stage am I when they come to see us before surgery. That question really can never be answered before surgery because we don't get the final stage until after the specimen is out and we know if there's involvement of lymph nodes. That's probably the most important part of your staging. And the reason I say that is, you can kind of group stage 1 and 2 versus the other two. You could think of 1 and 2 as the same. It's confined here to the wall. Very early stage. It has no real risk of lymph node metastasis because it hasn't spread deep enough. You can see here they're showing you lymph nodes here and then the blood vessels. Unless it penetrates deep enough into the wall to reach this, which is called stage 3, then it can't really access the lymph nodes to spread. So the way cancer spreads to your liver, to your lungs, to your brain is through either your lymphatic system or your blood vessels. And unless your cancer is spread deep enough into your colon wall, you have zero risk. And that's why it's kind of grouped. I say 1 and 2, you have surgery and you're done. You're cured. Stage, other than needing surveillance, stage 3 and 4, it's spread through your lymph nodes and possibly beyond that into your liver and lung. And the chance of cure is much smaller. I was very hesitant in putting this slide up, and only because people that are asymptomatic, feel like, well, should I need a colonoscopy or do I need a colonoscopy? I don't have bleeding, I'm not anemic, I'm not having any changes in my bowels. Well, I can tell you the great majority of people who are diagnosed with colon cancer are asymptomatic. There's just a screening colonoscopy and you find it, and when you reach the point of having obstructive signs or you're having 30, 40 pound weight loss and all these symptoms, you're probably pretty advanced in your stage of colon cancer because the thing has grown big enough to start causing symptoms. So that's, again, the importance of getting screened early, catching it before you start having symptoms and potentially curing this disease process. So when we talk about high risk, who's at high risk, who's at a low risk, that dictates your screening surveillance. And this is all really not important for you to remember, but more so for you to discuss with your family doctor, primary care, if you see a GI doctor, to know, am I at high risk or low risk? Because low risk patients need every 10 years. I mean, that's fairly simple. I've had 2 scopes myself. It's not a big deal. People really stress about having a colonoscopy because no one wants to think about someone entering their backside. But it's really, I mean, you're sedated. You don't feel anything nowadays. Now, some people say back 20 years ago they were not sedated. I can't imagine. But, you're sedated. You don't feel or remember anything. It's very easy. The hardest part of a colonoscopy is the prep. As those of you who've had it, you're gonna, you put a roll of toilet paper in your purse and walk around because it's going to be a long afternoon. But when you're talking about high risk, you're talking of people, first-degree relatives that have colon cancer. That does put you at high risk. All this should be known by your primary doctor, but we'll just stress that if you had a, the standard screening has always been 50 years old, you start getting your screening. Well, now they've moved that down to 45 recently, within the last year. But the only reason behind having this slide up there is what high risk means. If you have a first degree relative, such as a sibling, a paternal uncle, maternal uncle, someone that's directly related that was diagnosed with colon cancer, and that puts you at high risk. Now, if they were diagnosed at the age of 80, that doesn't really put you at any increased risk. The recommendation is to have a scope 10 years prior to them being diagnosed. So if you have a sister, brother, uncle that was diagnosed at the age of 50, then you need to start getting screened at 40. Or at 45, you need to start at 35. So that's just the significance of that. If you have a personal history of adenomatous polyps, like we talked about, polyps lead to cancer, then your surveillance will not be the standard 10 years, one every 10 years. It may be 3 to 5, and that depends really on your GI doctor and how many polyps he finds. Inflammatory bowel disease, ulcerative colitis, Crohn's disease does put you at a higher risk for colon cancer. So this was stressed earlier. So if you're low risk, you don't have any of these factors, and should you be screened? And as I stated earlier, 80% of all people who are diagnosed with colon cancer have no high-risk features, no family members, no ulcerative colitis, so everyone needs to be screened for colon cancer. These are kind of mentioned background of other risk factors, and you'll read about them online of, as far as race, African Americans, slightly higher risk of colon cancer. Diet, this is one that I was also resistant to put up, because you'll read a million things on the internet about, high fiber, low fat, don't eat steak, drink coffee, then don't drink coffee. It seems to change every 5 years, but the only real proven is a diet that's very high in red meat, which is a diet that I follow, is a risk factor for colon cancer. Now, I don't know, you read some studies that say it's maybe 5 to 8% risk of increase, some say 15. So some people think that may actually be due to people that tend to eat a lot of meat, maybe are eating a lot of fat as well, versus those who are eating fish and vegetables. So they don't know if it's actually the meat or if it's the high fat diet. So I wouldn't go, I'd probably get shot if someone heard me say this, but I wouldn't really so much focus on diet, other than things we know that are linked with every cancer, such as smoking, obesity. This is kind of a bummer. It seems that there's a lot of disease processes associated with being a male, so we take the hit on this one as well, as high risk of colon cancer in males. So for those, I'm sure you've read about a million ways to get detected, to have a screening test for colon cancer. If you read on the internet, or if you've heard, you can do a stool test. You can send a sample in they even have one for DNA now. Test for blood in your stool. There's a new test called a CT colonography, which you just go through a CAT scanner, and it looks, that sounds a lot better than being put to sleep and having a tube run up your rear end. But I'll say this about these things is there is prevention versus detection, right? So I would much rather personally go the preventative route versus the detective route. And what I mean by that is all these tests are trying to pick up, not the bottom one, are trying to detect cancer. This test is trying to prevent you from developing cancer. And what I mean by that, this test will be negative if you don't have cancer, right? But if you have polyps, it may be negative as well. Well, do you want to allow that polyp to grow and grow and grow until it bleeds, or do you want to tackle it from the beginning and have it removed? Same thing with this DNA stool test. You'll read about it on the internet. It's called Cologuard. I'm not against it, but it does not take the place of a colonoscopy. Cologuard's role, and you'll read on their website, it's about 90% sensitive for picking up cancer, which is great, but it's only about 40% sensitive for picking up a precancerous polyp. So, you're taking a big risk depending strictly on these tests. My advice, get the colonoscopy and just be done with it. Don't wait. You want to prevent, and don't wait until the cancer actually develops. Same thing with these little tests. The CAT scan, it's looking for a mass. All right. The flex sig and bariminima. The problem with the bariminima, in my opinion, the flex sig, all this means, This is a colonoscopy, but they don't go all the way around your colon. This is really reserved for people who have maybe have a very tortuous colon and the endoscopist couldn't get around, couldn't reach the end of the colon. It's not really practiced regularly, like such as some of these things that are taking the place of colonoscopy, which I disagree strongly with. So when do you start with your colonoscopies? If everyone will take out a pencil and kind of write down these guidelines. I was just kidding. So this is so confusing if you get on the internet. So when should I get a colonoscopy? Well, I mean, it would take me 6 months to memorize this thing. So this is what we go to primary care doctors for them to tell us when do we need that guidance. I mean, the colonoscopy. So don't memorize any of this. Really, basically, what I want you to get from this talk is, you know, challenge your physician that you see, your internal medicine, your primary. Do I need a scope? What's my risk factors? Because they're the ones that are educated about it and should have you, you know, about 1 in 3 people are not up to date on, or never had a colonoscopy. They're not up to screening guidelines. And you think about the incidence of cancer and how curable this thing is, it's really a shame that people are, maybe they're misinformed or misguided, or maybe they just don't have a primary care, which is probably the case more so. But basically, an easy thing to remember from this whole chart here is that if you're a low-risk patient, you don't have a family history, or you're not bleeding, and you should start at 45. And this is, I mean, take this message home, tell your kids, tell your family members, make sure they're getting scoped. And then for high risk, you know, there are some syndromes. I didn't really put them on here, but there are genetic. Most all cancers are not genetic. So is it a mutation? Do I have a genetic disorder? You know, probably about 85–90% of all colon cancers are not genetic. They're actually just sporadic mutations that occur in your chromosomes. So genetic predisposition, you may hear of someone having FAP or Lynch syndrome. Those are very rare. They account for less than 5%, so they don't really warrant much of a discussion other than these are people that are having their colons prophylactically removed at the age of 20. So you may not know anyone, but these people, 80 to 100% of them have colon cancer by the age of 40. So they have to have their colon completely removed by the time they're, I think it's 24, 25 to prevent, because they are going to get colon cancer. It's just a matter of time. And then your surveillance, like I told you, this is really up to your GI doctor. Once you have your initial scope, then your GI doctor will follow up and tell you, you had 0 polyps, we'll see you in 10 years, or you had 2 polyps, we'll see you in 5. So none of this needs to really be, memorized by you, but you should always, like I said, challenge your physicians. Now we're getting to kind of the part where I enjoy is the surgery management. I used to do scopes in Jennings, and I didn't really care for it too much, just because that's not what I trained. I like to cut people, and that's where my heart is surgical management. I like the thing that drew me into surgery more than anything else is, you know, it's important that we have internal medicine and primary care in the community to treat our blood pressure and sugar, but there is no real cure necessarily for blood pressure, I feel, or any cure for other chronic illnesses. However, when you have cancer, or you have, skin cancer or colon cancer, appendiceal cancer, thyroid, there is a cure. And I like that there is an end in sight in surgery, that we can go in and surgically, potentially, cure this disease process. And that's the part that really drew me into surgery is potentially giving someone a cure and hope that they can beat this disease. So just some basics on colon surgery. All these slides are basically stem off of questions that have been asked in my clinic by patients that are getting ready to have a colon surgery. So what does it mean to have a colon resection? Everyone always asks, am I going to have any colon left? You should, most times. So removal of the colon basically means a partial colectomy. So say if someone you had a colon cancer in your lower, so this is the beginning of your colon here. This is where the small intestine dumps, and then your colon comes across. It's almost like an upside down U. So if you picture on your abdomen, it starts here, up, makes a U, comes down and empties. So that's what you're seeing here. So say if you had a cancer right here in your colon, this is called the sigmoid. Well, if you look over here and follow me, the treatment is not that fancy. I mean, surgeons are not that smart. It's basically just cutting and sewing together. We take out this segment of your sigmoid, and we sew this to this, as you can see here. That is the treatment. It's not that complex. So when someone says they had a colectomy, it's usually a partial colectomy, removing just a portion. Now there is total colectomy. These are rare. These are the people that have the syndrome such as FAP, that have like 80 to 100% chance of colon cancer. They're taking out the entire colon and hooking the small intestine here into the rectum. And that's a pretty morbid procedure in the sense that, you know, the rest of your life you're probably going to be going to the bathroom 12, 15 times a day because you have no colon to absorb water. So how well do people tolerate a colectomy? Very well. I mean, a partial colectomy, you really would notice any difference in bowel movements. Your colon's job is to reabsorb water. That's its main function. So removing a small portion, even the entire left colon, you won't be fraught with diarrhea the rest of your life. Removing the entire colon, there's no question that you will, you'll fight that the rest of your life. Types of colectomy, this is not a very important colon, but when you hear of someone saying, a right colectomy, essentially, it's not rocket science. You're moving the right portion of the colon. The transverse is the portion I tell you that goes across, and then you have the left colon which comes down. So basically, in fancy surgery talk, right colon, left colon, transverse colon, it's just telling you the anatomical location. You can see the cancer here. Well, if it's on the right side, we're going to move your right colon. These are some more, a little more complex. An APR, you may know someone that has a colostomy for life or an ileostomy. And that's usually when you have an extremely or very low cancer, like last few centimeters of the rectum, which is really near the anus. And if you have to do a surgery down there, you will have no sphincter function, so you have to have a bag for life. And that's called an APR. It's basically when they take out your bottom end and they sew it shut and you end up with a bag for life. So that is extremely rare. I mean, I've actually in training we did a few, but I could say in 8 years with today's technology, with using radiation to shrink tumors up and get them away from the sphincters, it's extremely rare. I haven't done a single one in 8 years. So I think that's very rare that would happen, although I guess it does still. So this I showed you earlier, the benign polyp, and remember how smooth, looked almost like a little sucker dangling from the colon. Well, this is what a cancer looks like, and you can see it looks angry. It's red. It's very irregular, bumpy looking. This is a typical view of what a colon cancer looks like. Just a few reasons. As I said, I designed this talk initially just to talk about minimally invasive colon surgery. I swept in the cancer talk at the last minute. So going back to minimally invasive surgery, why would someone need their colon removed? Most common indication is diverticular disease. I'm sure you know someone that's had it, or you've personally been affected or hospitalized for diverticulitis. That's just diverticuli are simple outpouchings of the colon or weaknesses in the wall of the colon. As we age, it's not uncommon. A lot of us get diverticuli. The thinned out areas, as your colon is processing and reabsorbing water, it's compacting your stool. So that muscle wall in your colon will actually get thinned out and can actually pop. And that's when you get diverticulitis. If you have a small hole in your colon, it'll pop, and of course you have bacteria in your colon, then you develop an abscess or an infection, and that may lead you to an emergency operation. Other indications, cancer, of course, we talked about, and then larger polyps. Even if you have a large polyp such as here, and they cannot get it out with a colonoscopy, if it's over the size, usually we use a cutoff of about 1.5 to 2 centimeters. If it's larger than that, then it's recommended to go have, even though the biopsy may come back benign, it may say it's just an adenoma. A polyp that size has a very high risk of harboring cancer even deep inside of it where you're not able to biopsy. So it's recommended to go ahead and have that portion of your colon removed. Less common indications, these are very unimportant for this discussion, but I'm sure you've heard of, again, someone that's had gangrene of the colon or toxic megacolon, of course traumatic injuries, gunshots to the colon, infectious colitis. These are typically people that get, I don't know if you've heard of C. diff colitis. And then, of course, I mentioned earlier the prophylactic total colectomy for the syndromes. This is a very common question in clinic is I'm having part of my colon removed, am I going to get a colostomy bag? And the short answer is no. Anytime you have an elective colon surgery, the answer is usually 99% of the time there's no reason you should need a bag. A bag is reserved for emergent situations. And the only time I can think of if you were to have an elective colectomy and you may require a bag would be if you had an extremely low colon cancer, such as we mentioned earlier down here. The risk of that failing when we sew that together, there's a little a problem that can occur called a leak, and it's not a little problem. And if it leaks, you end up with another operation, and often a bag permanently. So if you have a very low cancer, you may end up with what we call a temporary diverting ostomy. But not to get off track, and a colostomy we almost never give during an elective colon resection. These are the indications, such as someone that had a diverticulitis attack and they blew out a huge hole in their colon, contamination, the stool spilled out and they're sick, septic. Then of course we're not going to go in that scenario, that environment, and try to think that we're going to play hero and sew things back together. We're going to give them a temporary ostomy for 6 weeks and go back in and reverse it later when the infection is resolved. And then the other indications I already talked about: gangrene, obstruction, lower rectal cancers. So surgical approaches, and this is just, there's many ways to skin a cat. There's a traditional open colon. This has been done since the beginning of time of surgery. And that just basically means the midline incision all the way down. This is very common, and actually the great majority of all colon resections are still done that way. Laparoscopic colectomies, you can group laparoscopic and robotic colectomies together. It's the same approach, same size incisions. Robotic has gained some momentum at different institutions, especially ones that have purchased a robot. I'll maybe talk briefly about robots. I'm not a huge fan, and then there's this new procedure, and this is reserved for rectal cancer. It's called TAMIS. I'll talk about that in the very end. So a traditional surgery, this is traditional incision up and down the midline. So it's called a midline laparotomy, and this is, you know, what it looks like with the belly open. So this is the scar you're looking at. This is a traditional, like when I say a traditional surgery, this is going through residency. We do 5 years of surgery training. I can tell you I probably did 95% of all my colons open, because the guys teaching you generally tend to be established, have been out for 20, 30 years, and they didn't have laparoscopy when they trained. So they're going to teach you what they know. Technically, it's a lot easier to do it this way. You know, if you think about trying to look through a small hole versus just cutting someone wide open, of course, this is the easier approach. Anatomically, it makes more sense when you can go in and you can see every organ in there. It's just a comfort level for the surgeon, if that's how you were trained. And then when you hear about minimally invasive, such as this talk, or you read about spine surgery, there's a million commercials about minimally invasive spine. Spine basically, or minimally invasive, basically just refers to laparoscopic or robotic surgery. And it just means making small incisions, using a camera to go in and visualize in the abdomen. So just a little history lesson on laparoscopic surgeries. Actually, I was reading the other night, they actually started doing this in 1901. This is one of the first ones done. They actually had to put your eye directly up to the scope. I don't know how sterile this could possibly be, but this is how laparoscopic surgery started out. It's pretty impressive, but they actually started operating on cats and dogs, of course, in the beginning. And they were using this a lot in OB if a female was pregnant, just to look inside the abdomen if they were having problems with the pregnancy. And then also in traumas, they started sticking these in to look and see if they were worried the patient was maybe bleeding to death internally. Make a little hut and put a camera in there and look through it, see if there's blood welling up versus having to go cut them wide open. The first appendectomy was performed in '81. The reason I put these two down there, the first gallbladder versus the first laparoscopic colectomy, if you look at the difference, the first gallbladder in '87, now 98% of all gallbladders are done this way. And look at the difference in colons. It's only 3 years later, only less than 30% of colons are being done laparoscopic. And that's just due mainly to a lack of training. Like I said, we're all, you know, just a product of our environment, and if you go to a program where you're trained to do it open, you're not going to come out and just start doing these laparoscopic. It's almost like a test lab rat. You know, you don't want your patients to be lab rats. So unless you're trained this way, you're probably going to continue to do them all open. And it's not necessarily a bad thing. I'm not saying open is bad. But this is just a look, kind of, people are always interested, what does it look like when you're inside the belly laparoscopic? This is basic, I mean, this is a cartoon sketch of, basically there's a camera that goes in, and basically we put 2 to 3 of these little graspers. They're 5 millimeters in size, so less than 1/4 inch inside, and this is how we grab organs. In this case, this is the uterus and ovary. We use these little graspers and we grab, move things around, or resect the colon, take out the cancer. So basically this camera has a little port attached to it right here, you can see it, and it blows air to puff the belly up. So brings the belly away from the organs, and that way we've created this whole space where we can see. So that's what laparoscopic surgery looks like. I wanted to show you, this is how fancy we've got now. We have 3D cameras. I mean, it really is nice, like the picture versus, you know, we've come a long way. Unsterile, sterile, 3 TVs, no TV, high def TV. I mean, I wish I could, I didn't have time to put a video, but it really is impressive to see like how detailed, and it's really a great view. We're really lucky. So this is just, I don't know how well you could see these, maybe if the lights were dimmed a bit, but this is just a look inside, looking at the stomach, and you can see how, versus earlier, looking at this, I mean, I don't know if you can appreciate, this is the stomach, but that's not really, I mean, it's just a bloody mess to me. And then you come here, I mean, look how beautiful the anatomy is here. It's much easier to see, delineate where the stomach is and the vessels involved with the stomach. This is the most common laparoscopic procedure done in America, which is a laparoscopic cholecystectomy. And this is the liver here. This is a grasper coming through a port. You see, these are the little ports I showed you where come in. This is your gallbladder, and this is a little fat stuck up to it. So this is kind of what it looks like, and you can see how clear the picture is. You can see the small little vessels in the abdominal wall. I mean, the details are scary what you can see inside of these with these cameras. So open laparoscope versus laparoscopic, this is just sometimes smaller, maybe better. And in my opinion, it is. Now, not everyone is a candidate for laparoscopic surgery. It really depends on if your surgeon, their comfort level, and most importantly, probably to me, and evaluating someone to see if we can do it laparoscopic is the location of the cancer, and then secondly, the patient's history, surgical history. If you've had 10 abdominal operations, probably not going to be the best idea to do it laparoscopic. You're going to have so much scar tissue, we'll never be able to see anything. You have to draw a line, laparoscopic versus open, and you know, we know that there's a direct correlation in how long you're laying on that table asleep and complications. So we're always very efficient, and we're very cognizant about how long our patients are asleep. So if I get in there with a camera and I muck around for 10 minutes and I'm not making any progress, well, you know, it's kind of go time. We're going to open, we're going to get you off the table. My wife and I are very fortunate. We have each other. We're both surgeons. We train together. We know what exactly each other's next move. So we do every colon surgery together. And we cut the time down, I mean, in half. Actually, I was going to be late today. We did a colon, and we did it in about 30 minutes. So, I mean, the average colon operation is about 3 hours. So being together, she and I can kind of bounce off each other and go very fast versus using a tech that's in the room. Nothing, I mean, they help greatly, but you know, they can't staple across the colon or resect or help you tie. So anyway, I'm getting off the subject. Back to open versus laparoscopic. So being a candidate for laparoscopic, you know, that's really a discussion with your surgeon. There's a ton of surgeons who do these laparoscopic. There's, you know, my wife and I here in town, there's a guy here in town who does them robotically. We never really encourage patients to come to us. I'm more than happy to sit with anyone that has colon cancer and discuss, you know, surgical treatment plan, what you should do. There's a lot of people who, you know, the comfort level is going to Houston. I encourage them, if there's any question about your care and you feel more comfortable in Houston, then go, because God forbid we do it here and you have a complication and you're going to doubt. You know, complications, they happen. 5% of the time with colon surgery, you may get a leak. And it's not necessarily a technical issue. It happens in Houston, it happens here, it happens in, Australia. So I always am more than willing, like I said, to meet with you, discuss the prognosis or the surgical plan. And then if you, want to go to Houston, I know people there that, that do this procedure, and I'm more than happy to help you get there. So people are off. I say that only because I've had a few patients who it's been some awkward encounters, including a personal, not a personal friend, but a friend of a friend who they really wanted to go to Houston. And, I said, it's not personal. I mean, it's your care. I had heart surgery done when I was 28. I went to Houston. I was like, I didn't know any heart surgeons here. So of course you're like, well, let's go to the big city. So just be thorough, research your surgeon, and if there's any question, like I said, I'm always happy to meet with you, talk with you on the phone, and I can make recommendations where you could go should you or your family member be unfortunate enough to encounter this disease. And then of course the indication, when it's an emergent situation, we don't go in with the camera. If someone's dying from an infection or gangrene of the bowel, that's not really, the camera has no role in that situation. So incision, so if you're comparing laparoscopic versus open, you can tell I'm a little bit biased here. I'm showing the open procedure. This is what a laparoscopic procedure looks like, 5 millimeter incisions. In the end, the biggest cut will be near the navel, which is here. So you can compare open versus this smaller incision here. And of course, this is called an extraction site. So the extraction site, of course, your colon is probably 2 to 3 inches in diameter at least. You have to have somewhere to take it out. We could do the whole operation through these little bitty cuts, but we have to get the thing out in the end, the cancer. So you will have an extraction site in the end, but this is much better than this, right? Yeah. So statistically speaking, there's this slide. There was a study, a huge study was done out of Houston by Dr. Haas, who you may or may not know. There's a lot of people who go to him, and he's an excellent surgeon. They looked at over 51,000 colon surgeries that were done, and they compared open versus laparoscopic. And this study screams in favor of doing it laparoscopic. As you can read here, length of stay is cut in half, and that just makes sense. I mean, if you're trying to recover from this wound versus this wound, you know that your pain is going to be less. You're going to be out the hospital quicker. So it's not surprising that your time in the hospital is cut in half. Post-operative pain, and actually the hospitalization cost is decreased by about $10,000 having it done laparoscopic. And then the most important thing to me as a surgeon is it the outcome going to be the same in terms of, the pain, all that stuff is fine, but is your oncologic outcome or your survival going to be the same? I mean, you don't want to tweak with something that's worked for a century if you're not going to get a good lymph node dissection, or your margins on your cancer are not adequate, and people are popping back with recurrent cancer. Well, the studies have shown there's no difference. They're equally effective in treating. Your survival should not be affected by open versus laparoscopic. Just a brief mention on and I talked about newer technology. This is pretty exciting stuff. I went to a course last year on this in Nashville called TAMIS, and this is a reserved for low rectal cancers, and which is actually not that uncommon. Now, I don't mean low like we're talking about, I'm talking about 5 to 12 centimeters from the anal verge. This procedure, this is hard to I didn't want to show anything too visual. People may get grossed out by some of the pictures, but this thing here, this is a port, just like we have on the laparoscopic. This thing actually goes in the anal canal. Of course, you are sleeping. This is like, it's it's not as big as this picture, I promise. But it's like having a colonoscopy, all right? So you're asleep, this goes in there, and through this, we can actually blow the colon up and we get this picture. You can see here, this is a cancer of the lower rectum. We mark out the edges, and then we take it out. And then we sew it up, and you go home the same day. Isn't that crazy? Versus being in the hospital 5-7 days. So this is very new. It's been around, I mean, I say new, it's been around 10 years, but it's gaining a lot of momentum. And we don't know the exact how far we can push this as far as what stage of cancer, but we know that this is very safe for people with early stage, such as a T1. There's no difference in survival. People are having, the outcomes are exactly the same. We use this, say if you had a large polyp that needed to be resected, you had to have your colon removed. Well, man, I mean, what a winner this is for taking out a large polyp. You don't have to have your colon removed for a benign polyp. And then carcinoid tumors are not worth mentioning. They're so rare, but every now and then we don't know what to do with these little, they secrete hormones, and they're found typically in the rectum. And so sometimes people get a carcinoid syndrome, flushing, sweating, feeling hot, losing weight, and they have a scope for some other reason. They find this little bitty mass called a carcinoid, and they don't, no one really knows. You obviously don't want to go take someone's rectum out for a little bitty benign tumor, but if you can have a TAMIS done or a transanal microsurgery done to remove this and go home the same day, it's similar to having a colonoscopy. Then man, it's exciting technology, but they are stretching this thing now to doing T2, which are a little bit larger cancers that invade a little bit deeper, and we'll probably will have more and more data coming out on that. But for now, they're very strict on what you can do it on as far as location and the stage of the cancer, but it is exciting stuff.
Is it being used here in Lake Charles?
Yes, I'm the only one doing it in Lake Charles right now, but it's the GI doctors here know about it. They're the ones that I don't scope anymore, so they find the cancers, and we, they'll refer if it's a low rectal cancer that meets the criteria for it. This is a slide. I'm not going to read it. It's just kind of the last slide of the day. Just some facts to read about colon cancer. I think the surgery stuff is fine for me to mention. The surgery stuff is very cool for me to talk about. I like doing it, but the bottom line is, my wife sits on the cancer committee here, and she mentioned night before last that they're reviewing the colon cancer cases, and the majority of colon cancers that are being diagnosed at this hospital are already in stage 3. So that's very scary that your survival can be 94%, but by not getting screened, these people are not getting their screens and they're catching it late. I mean, your survival is cut less than half, and so if we can do a better job as patients and as providers to prevent this from occurring, it may decrease my business if we're catching these polyps and remove them, but I mean, it behooves us as physicians and it behooves you as a patient to really stay up to date on your health and make sure, push your physician to make sure you're up to date on colonoscopies and mammograms, all these things, these cancers that are preventable, because there's a plethora of cancers that are not. Pancreatic, we don't have a way to detect it. By the time you detect it, it's spread. Cat's out the box. So, I mean, this is something that's preventable. It's very important to be up to date on your screening. I encourage everyone, if you haven't had one, call your primary, call my office. I can get you in to see one of them. Encourage all your family members to get their colonoscopy. And that's it. I thank you all for your time. And if any questions,